So I'm Leif. I'm very pleased to meet you, Dr. Parkash Dhillon.
Yeah.
And thanks for coming by.
Oh, thank you.
Where are you from in India?
I am from Amritsar. It's 250 kilometers towards north, just near the Pakistan border.
Yeah. So we are going to talk about the patellofemoral system that we are launching with this meeting, really. And for for more than 10 years, we've been addressing the focal cartilage lesions in the knee with implants that we resurface the cartilage. And this is done by this technology where we use MRIs. We reconstruct the knee in the computer. We produce instruments that are patient-specific, that fit, and you can feel yourself how well that thing it dumps down, and you can't twist it, and it fits very nicely. And we make it so, you see, you can slide it this way. So we make it so this border coincides with that border. So this is how it's supposed to sit. And then we pin it down using just ordinary K-wires. Boop, boop, boop. And this will sit very tightly. And then we have, if we have a trochlea with a twin, we have this twin configuration. If the lesion is oblongated, or we have a circular lesion in the trochlea, it's small one. And then for the twin we have an insert like that we can twist around. And then on top of that we put, we put this one in first to make, using the drill down like that, to make a shallow hole, a central hole. And then we take this away. Oops, we need the insert like that. And this is our adjustment socket, which I find ingenious. So you can twist this, and then by twisting it, you incrementally deepen the drill by 0.2 millimeters. So we work our way down into the cartilage and bone until we can see that the implant will sit slightly recessed below the surrounding cartilage. And we check that with a dummy like this. And this is a perfect replica of the implant. And we put that down, and then we can feel with a wire, or we can just have a look until we're satisfied. Of course, when you have osteoarthritis, that we are talking about now, you want the implant to sit not recessed below the bony surface, but you want it flush, or possibly even a bit proud, according to your personal preferences. So that's a femur, and that is basically the very same technology that we've been using. Now,
it's the same if the defect is more or less
Yeah, we can put it any. I mean, the guide can sit here, it can sit here, it can sit like that, and you will find the strangest twisted shapes of the implant, depending. But once you get it down, it fits perfectly. And it's all about math, really, because we have the DICOM, we get it into the computer, we construct the knee.
So we know the exact place of lesion.
Yes, and I will, and I can show you here what we do here is the patellofemoral system, and we do an MRI. We reconstruct the knee in the femur and in the patella. The lesion is drawn onto. The pink is where it's less than total, so it's a somewhat more shallow damage. The deep red is a full thickness lesion. And then we suggest the positioning, and then we send that damage marking to you over the net. And you have a look at it and you say, nah, I don't want it like that. I want the implant to sit more on this side or that side. Okay, we say, and then we communicate, and then we're happy, we say, okay, fine. And then it takes us 4 weeks to manufacture it. And I hear from your colleagues that you would want that to be shorter, because patients in India, they go to a second opinion, a third opinion, a fourth opinion.
Yeah.
And if you don't have a robot or a patella system, so we're working on that, but for the time being, that is just the way it is. And by the time we also provide you with a set of slices, MRI slices, the relevant, and to show you the projections of the implants that we suggest in various projections. And together with the kit comes the final design to show you how the guide is supposed to sit on both sides. And in the patella then, this is how it looks. The same principle, and you will find that fits very nicely too onto the patella. And then you pin that down, and we do the same thing here with this one in, a central hole, and then this one, you twist that until you're happy, and you have you have the dummy, it is here, and you see that you're happy again with the correct depth, flush or subsided or even proud, whatever. And then you pin it down using the implants, and you see here, this is a 𝗍𝗁𝗵 thing. The articulating surface is patient specific. The surrounding surfaces here are coated with titanium and then hydroxyapatite. This is 𝗍𝗁𝗵. And we found that, we knew that hydroxyapatite can give you osseointegration.
Yeah.
What we found is that it also gives you chondrointegration. So the cartilage actually grows up. And we have a publication that you'll get. So it means that we are effectively sealing the hole in the cartilage, so that joint fluid is not squeezed down, providing osteolysis and loosening. And we haven't had a single case of loosening so far in almost 2,000 cases. The patella button this is a fake plastic. It's state-of-the-art, high molecular weight, cross-linked vitamin A doped polyethylene to be the best possible. That is cemented in place with cement pockets, and just the ordinary way. And what we cannot give you are follow-up data, because we've only put in a couple of these yet.
Okay.
It's being okayed in the US, in the United States.
FDA has approved.
Yeah, FDA has approved it, and so we're launching it here too, on a customized basis. So we are actually doing this on a recipe from you, and this is how it works in India. And so there you are. What we do know is that, and that's the reason why we got the okay from the FDA, was that there are similar devices on the market.
Yeah.
And there is no reason why we should be worse. We should actually be better, I think, because our very precise instrumentation and our patient-specific implants should not be worse than anything else that's out there.
But you know, in India, the patients are coming very late. If they have small problem in the patellofemoral, they keep on lingering with the medicines, and they continue with that unless they have various whole damage. So
yes, well, and I suppose that's why that's why we thought perhaps, because I hear that the femoropatellar arthritis is common in this country.
Yeah.
So there you are.
So, okay,
we should be able to help you with your patients.
Okay, let's see. Hope.
Yeah.
So what's the cost?
Yeah, the cost.
Cost is 3.75. You're looking for insurance companies.
Yeah, we're working for insurance companies.
So,
It's, I suppose it's.
so how deep it will go in the femur? This.
It will go. It will go some. I mean, this is a femoral. So we will go this way down in the trochlea. What we've done is we've checked with a number of standard total knee instrumentation and made the cuts using standard.
Yeah.
And what we see is that in most cases we excise the entire footprint
Okay.
of
Cut is going underneath this,
yeah.
below this.
Yes, right. And if it depends a bit, sometimes they sit very strangely, and so a bit in the camphor cuts, but there will always be contained defects that you can fix with
the
bone chips or bone
yeah,
cement.
Yeah, bone.
So,
From this.
so we have had revisions. We've had about 35 revisions in close to 2,000 cases. So the revision rate is extremely low, but all the ones, they are being revised to uni knees or total knees, and that's been no problem with that. So
Yes. It's a good effort. So,
yes, well, we hope we hope we have something to add to the market that the market needs.
Okay, we will try to find the patients.
Yeah, yeah.
Your
Well,
eyes,
hopefully.
one says your eyes can't see those things which your mind doesn't do.
Yeah.
So we know now that there's a solution for this, so we will try to find the patients.
Yeah. Good. Thanks for coming by.
Thank
Wonderful.
You, thank you.
And we will give you this.
Okay.
And here you have the manuals, and you have relevant publications